I want to start my talk by thanking Dr. Puyana and Dr. Maria Jimenez for the invitation to come to Medellin. It's really a pleasure to be here. And thank you very much for putting my lecture right in between titans of trauma. You know, you've got all these big guys, and all of a sudden, I'm there in the middle. Thank you. So let's talk a little bit about a lab test, teste de laboratorio, que mede la coagulación, llamado TEG and ROTEM. And the question is, does it really help? So I have nothing really to disclose. And let me say, 3 años atrás, Maria Jimenez, I was in Bogotá, and Maria Jimenez called me on the room. Eu tive que sair do room, e ela falou, tua esposa está no hospital, e ela está te chamando em telefone. And I, oh my gosh, my wife, oh, she's sick. And actually, quando saí e peguei o telefone, minha esposa said, temos boas notícias, estou embarazada. And so I'll always remember, eu sempre vou lembrar Bogotá. And that's the result of the Bogotá. Here it is. That's Daniel saying hello para todos ustedes. Muchas gracias. Okay. Let's talk about TEG and ROTEM. So a few things that are important here for us to know. Oh, I have my tower. Fact number 1, trauma patients bleed a lot. Todo trauma, paciente de trauma, sangra mucho. Todos nós sabemos isso. Correct? Segunda coisa. I'm sorry, I'm really mixing up my English and Portuguese, Spanish. So it's, I'll probably stick to English. Is that okay? All right. So the second thing that we all know, there are 2 types of bleeding. There's the mechanical bleeding. There's when you have a hole in a blood vessel, or you have an organ that's cracked. You have the spleen, just like Dr. Peitzman talked there, you have a spleen that's cracked and it's bleeding. That's a mechanical bleed. How do you treat a mechanical bleed? Surgery. You go in there and you put your finger in the blood vessel, you go in there and you remove the spleen. That's easy. But there's another type of bleeding that's coagulopathic bleeding. And that's the bleeding that's the consequence of the patient not being able to form a good clot. Trauma patients can't clot well. They have a clotting problem. That's coagulopathy. And how do you treat coagulopathy? Is with plasma, platelets, fibrinogen, blood products. Okay? Third thing we have to remember is that until 2003, we thought that this deficit of coagulation was because the patient bled. We thought the patient would bleed, they would lose all their clotting factors, and then they would become coagulopathic, something that takes time. It's a secondary problem. 2003, there was a paper by a British surgeon called Brohi that said that's baloney. The patient becomes coagulopathic immediately after the trauma. There is a primary coagulopathy associated to trauma. You don't have to bleed to become coagulopathic. You become coagulopathic immediately the moment you're hit, according to how much tissue you have destroyed, according to shock and so on. And also, we have learned not only that it's endogenous, let me see if I can press the right button, not only that coagulopathy is something endogenous or primary, but also 1 in 4 patients will arrive to your hospital unable to clot appropriately. And the mortality of that patient goes off the roof. So because we know all this, since 2003, you cannot resuscitate a trauma patient without thinking about coagulopathy, because 1 in 4 can't clot. So you have to take that into account. The problem is, how do we diagnose that? How do I know if my bleeding patient is bleeding because they have a cracked spleen, or that spleen can't stop bleeding because my patient can't clot? How do I know that? So that's why today we have a lot of this conversation. We're going to have more, that when you don't know, what do? You close your eyes and you treat this patient as if this patient were coagulopathic. You give this patient plasma and platelets to start with. You assume, you presume that they are coagulopathic. Is that correct? How many patients are coagulopathic? 1 in 4. So if you start giving plasma to everybody who's bleeding, you're going to be giving plasma to patients who are not coagulopathic. Okay, so let's do blood work. We can do lab tests like INR and PTT. But we know that those lab tests are not good. They were never meant to be used in trauma. They take too long. They correct the temperature before doing those tests. And those tests have no correlation with bleeding. So they are not good. So the question is there another test that maybe can help us? Good question. So that's my lecture. Is there another test that can help us? And the question is TEG and ROTEM really helpful? So those are 2 lab tests that have been around for 50 years. Who here has ever heard of TEG ROTEM? Quem ha ouvido? Mas existe por 50 años. E tu não has ouvido a respeito dele? Probably because it might not be that great, actually. So that's one thing to start thinking about. This is not a perfect test either. But does it help in trauma? It has not been tested in trauma. It's only now actually started being tested in trauma. So TEG ROTEM are 2 different machines. Okay? How are they different? So the big difference between TEG to ROTEM is this one here. TEG is made in the US, and ROTEM is made in Germany. They're very similar tests. Actually, what happens is there is a little cup. Go back here. There's a little cup. You put a little bit of blood inside the cup, and then a pin comes down into the cup. And in one machine, the cup shakes. In the other machine, the pin shakes. See, a completely different test. And then as the liquid blood becomes harder, as a clot starts forming. So you can see here is no resistance on the pin. And then as the clots start forming, you get this graph in here. So this here measures the resistance. So here's liquid blood, and here's a clot that is the strength of the clot, how strong this clot is. And then here is how quickly this clot dissolves. So it shows the whole picture from the beginning of the clotting to the clot strength to lysis, to how quickly this clot goes. So it gives you a whole picture. Second thing, it can be done at the bedside. You don't have to send the blood to the lab to have it done and wait for 1 hour until you get the result. And then the other beautiful thing about this here is that, let's say it's taking too long to start clotting. It also tells you, look, you can correct this. Give plasma to this patient. So let's say, in another situation, the clot, as you see here, is too weak. It's a wimpy clot. What does that mean? It means the patient needs what? Platelets. Very good. So it means the patient needs platelet or fibrinogen, in fact. So you know, depending on the problem too, how to treat the coagulopathy that you're diagnosing. So not only you diagnose the coagulopathy, but you also know how to treat it. The 2 graphs on the 2 machines are very similar. So here's the TEG curve, here's the ROTEM curve. You can see they're exactly the same. They just changed their names, and so it depends where you are. The difference with ROTEM, the European machine, is that the ROTEM gives you 4 graphs. But I'll tell you that right away, there's only 2 graphs that we care about it. Are the graphs that measure the extrinsic pathway, that's exactly the one from TEG. And then what they do here, they get this curve in here, and then they kill all the platelets in it by putting a poison to platelets inside called cytochalasin B. So what you're left with is fibrinogen. So when you do TEG, you can see how good the clot is, and you can also tell right away if this patient needs fibrinogen or not. It's the same curve, just that lower curve, there is a poison for platelets. Okay, so let's see how smart you are, how intelligent you are. So vamos testar tu inteligência agora. So, lo gráfico A la izquierda é um gráfico normal. So agora eu quero que tu me diga qual é o problema no gráfico de lá, do canto lá, do lado esquerdo. Qual é o problema? Que é errado lá? What's wrong on graph number 2? What's wrong? What? I didn't hear. Mucha coagulación. Actually, that patient there on the side is hypercoagulable. Hay mucha coagulación. Quando has tu feito esse diagnóstico? When did you make the diagnosis of hypercoagulability? And you know what? In fact, a third of the patients, even bleeding patients, a third of them are hypercoagulable. Their coagulation system is turned on, actually, in fact. And many of these patients end up getting plasma simply because they're bleeding, actually. So if you don't do the TEG, you maybe end up giving plasma to patients who have pure mechanical bleed, or not coagulopathy. How about this guy here? What's the problem with this guy here? Hypocoagulable. It's not clotting well. So this patient here are the ones that usually we see. And now how about the last one there? You win a car if you can get that one right. Okay, that's right. What's the problem with that one there? Muy corretamente. So, que temos aqui is hyperfibrinolysis. Actually, the clot is dissolving too fast. Okay? So, a few things about TEG and ROTEM. Now that you know how to interpret TEG and ROTEM, the number one is TEG and ROTEM are not INR-PTT. Forget about that. It's incredible. There's a recent paper, beautiful paper actually, that again tried to show that TEG and ROTEM are like INR-PTT. They're not. They're different tests, completely different tests. Okay? So what are TEG and ROTEM really, really, really good for? So if you learn these two things today, I'll be very happy. Okay? So there are only two things that TEG ROTEM help you with. The number one is excessive fibrinolysis, excessive clot breakdown. Okay? So here it is, a test. You see this tag here, you can see the clot is forming, the clot is very weak, but the clot dissolves very, very quickly. You're going to see this on very few patients if you do TEG in every one. So this is a good example, a patient that we had recently. Patient came in, very stable, all the blood work looks good. Look, the blood work looks really good. TEG saying this guy has excessive fibrinolysis. The surgeon called the OR and said, I want to operate on this patient. OR said, I have an appendix going on, can you wait? And the surgeon said, of course. An hour later, this patient is crashing. This patient died, actually. This patient had a mesenteric laceration, and he died in Toronto, in Canada. So the reason is because when you see excessive fibrinolysis on the TEG, that's a death sentence. It's rare for you to see that, but if you see that, your patient's going to die. In fact, many different publications have shown these rates of mortality when there's hyperfibrinolysis. In my hospital, if a patient comes into Sunnybrook and they have excessive fibrinolysis, 73% of them die in the first 6 hours. So it's so, and there's no other way to make this diagnosis. There's no other test that will tell you this patient has hyperfibrinolysis. So right now in my hospital, we have changed the way we treat these patients. If the patient shows up with excessive fibrinolysis, we forget everything. We aggressively resuscitate this patient. There's no delay in anything we do with these patients because we know they're going to die if you don't do that. And actually, the last 3 hyperfibrinolytic cases that we had, all 3 survived. Maybe it's just a coincidence, but with a mortality of 70%, that's quite an improvement. So TEG and ROTEM gives you a diagnosis that no other lab test does. Excessive fibrinolysis. TEG and ROTEM gives you another diagnosis that's very important, and that's clot strength. Quão fuerte es tu coágulo? How good, how strong is your clot? And that's easily measured on the MA. On this measurement here, on the ROTEM is that measurement there. And I'll tell you, there's only one number you have to remember. It's the amplitude at 5 minutes. If the amplitude at 5 minutes is below 35, You can read all the papers here if you want, all the reasons why I'm saying that 35 is the magic number. This patient has a clot that's not strong enough to stop the bleeding. This patient probably is going to go to massive transfusion, probably is going to go for massive, massive resuscitation. How do I treat this patient? What does a patient with a weak clot needs? Okay, sorry? No. Plaquetas and fibrinogen. Platelets and fibrinogen. That's what this patient. So does this patient need plasma? No. This patient needs platelets and fibrinogen. And that's the problem of going blind, of blindly resuscitating this patient with a ratio. It's okay initially. But after a few minutes, you need a lab to tell what the problem is. You may be giving plasma to a patient that needs fibrinogen and not plasma. You're giving the wrong product if you go blinded. Start blinded because there's no time to wait. But after a few minutes and so on, start getting your lab. You need information. So then you can treat this patient appropriately. So today in Toronto, in my hospital, we have both TEG and ROTEM. But what we did, we leave the ROTEM in the lab, and it is directly connected to the trauma room, operating room, and blood bank. Automatically, as soon as the machine turns on, the screen in the trauma room turns on, and whoever is resuscitating the patient, just look on the screen and say, look, the A5 is below 35. Guys, call for platelet, call for fibrinogen. Or they see the patient has excessive fibrinolysis, they say, forget it, this patient has to go to the operating room now. Okay? So it really, really helps us with that. So we're now working on developing guidelines. There are a few guidelines that have come out based on TEG and ROTEM, how to transfuse patients in trauma. There are good guidelines for cardiac surgery, for liver transplantation, a few guidelines for trauma. They are reasonable, but they may not be that great yet. So we're trying to work on developing new guidelines based on the ROTEM. And our goal will be that if a patient comes in and has, let's say, a clot that's very weak, while I'm trying to resuscitate that patient there in the trauma room, the blood bank automatically will read the TEG ROTEM and will start preparing the blood product that I need, even if I, as a doctor, don't ask for that. So we don't have to call the blood bank and say, I need fibrinogen, but the blood bank will send fibrinogen down, and they're going to knock on my back and say, Dr. Rizoli, your patient needs fibrinogen. So that's the goal where we're going to develop guidelines. So to end this year, I'd just like to show you a case that we had recently, and this was a patient that came in reasonably stable, and not reasonably okay, but this patient here had this ROTEM. So you tell me, what's the problem with this ROTEM? So the top one is the XTEM, the lower one is fibrinogen. So what's the problem with this patient? Is it excessive fibrinolysis? No. So I told you that TEG ROTEM only measures two things, excessive fibrinolysis and clot strength. So what's the problem here? What's the problem? Clot strength. This is a weak clot, and this patient is bleeding nonstop. And then this patient also tells us one more thing, he's Jehovah's Witness. He doesn't take blood. So besides operating and stopping the bleeding on this patient, what else should I do? Give this patient what? What does this patient need? ¿Cómo? Plaquetas or fibrinógeno, huh? Or fibrinógeno? Fibrinógeno. This patient needs fibrinogen. This patient is Jehovah's Witness, but Jehovah's Witness will accept fibrinogen concentrate. And actually, this patient here, we treated with fibrinogen concentrated, and he stopped bleeding. Okay? So you see how helpful it is. So as I say, my opinion is, if you have a trauma patient bleeding, you assume this patient is coagulopathic, and you start blindly throwing platelets and plasma on this patient. But as quickly as possible, get lab to help you. I can't see justification in the 21st century for a trauma center, at least in Toronto, not to have lab guiding your resuscitation. At least after the initial hour or so, you have to do goal-directed. You have to correct the problem that the patient has, not be throwing everything at this patient as if this patient needed everything. Because you're going to be giving the wrong thing to the wrong patient at the wrong amount. Okay, conclusions. Okay, that's my last slide. Since 2003, you cannot resuscitate a trauma patient without taking into account that this patient may not be clotting appropriately. 1 in 4 of the patients that you're going to see, they have a coagulopathy. They can't clot appropriately. Okay? Second thing, get lab to help you, but labs may not help you completely. Lab tests are limited for trauma. Is TEG and ROTEM the solution? I think maybe it is. I can't tell you for sure, maybe it is. I'll write a few more papers that I hope Dr. Moore will accept into the Journal of Trauma for publication, and to prove that point, but maybe it is. But in my opinion, TEG and ROTEM add to the current resuscitation. They are not a substitute, but they add, and they tell you 2 things: how strong your clot is, and also if the patient has excessive fibrinolysis. So once again, I want to say thank you very much. It's really a pleasure to be in Colombia.